and it's really good at softening gutta perca. And it has some antibacterial action as well. And patients like the smell of it, and so do I. So do my staff. It's biocompatible as well. It doesn't evaporate. It will eventually, but it doesn't evaporate when you put it in the canal in that short period of time. It doesn't soften the GP instantly. You've got to give it a little bit of time. We're only talking of maybe 15, 20 seconds before it starts to soften it. It doesn't leave a smear of the gutta perca on the canal walls like some materials do, or some solvents. As I said, it smells good and it's cheap and it's readily available. If eucalyptus doesn't work, sometimes, but not very often, and I can't remember the last time I've used chloroform. That would be my next choice. But chloroform is actually a very toxic material, and it leaves a smear of what's called chloroperca. So it's a mixture of the chloroform oil, which is what it is, with gutta perca in it. And that's hard to remove. You have to actually remove that with alcohol, so that adds an extra step into your whole process. So you're going to have another irrigant, just alcohol, to get rid of the chloroform smear that you've created. Chloroform also evaporates very quickly, and it doesn't smell very nicely, and it's a toxic material. So you don't want to be breathing it yourself, and you shouldn't really be giving it to your patients unless it's absolutely necessary. So I will only use this if eucalyptus doesn't work, and that's not very common. As I said, if you use chloroform, you have to irrigate with alcohol then to get rid of the chloroform. Another option, if you know that the cement that was used was zinc oxide eugenol, you could use orange oil if the eucalyptus doesn't work. Now, most times you don't have to do that, because one of the main reasons we use gutta perca for a root filling, and not just cement, is the gutta perca fills the space. If you just put cement in the canal, it's very difficult to remove, unless it's not a very good cement. The idea with gutta perca is it fills the space and it makes it easy to do retreatment, because we can drill that out with Gates Gliddens and we can soften it with a solvent. And so the cement that's in the canal is actually not very much once you've done a root filling. So if you can get down through the gutta perca with your eucalyptus, any cement that's left on the walls you typically get out with your files or your Gates Glidden. So it's pretty rare that I'd need to go to orange oil or chloroform. And I said, I can't remember the last time I did it. I put my eucalyptus in a syringe with a needle, just my usual irrigating syringe. Make sure you know which syringe it's in. So if you have, for me, I have my EDTA and I have my sodium hypochlorite, and I then have my eucalyptus. I need to know which one is which. I overcome that by having my EDTA in a larger syringe, because I use that as my main irrigant, and that's a 5 ml syringe, my sodium hypochlorite in a 2 ml syringe, and I don't open up my sodium hypochlorite syringe, I don't take the cap off the needle or anything until I need it, which is when I finish my root canal preparation, finish the filing. So I keep that actually off the tray when I have the eucalyptus there, because that we also put in a 2 ml syringe or 2.5 ml syringe. And you can see we only put a little bit in, probably a mil or even less. You don't need much in a canal. Canal's pretty small volume. Make sure you have rubber dam on, as you should anyway, but also make sure that your solvent, it doesn't matter which one you're using, you don't want your solvent touching the rubber dam, because rubber dam is just like gutta perca, it'll be softened by the solvent. You suddenly see your rubber dam opening up a great big hole, and you've got to replace it. So just keep it in the canal. Don't sort of irrigate to flush it all out, just keep it in the canal. That's where it's going to work. And really the only bit of your solvent that's working is the bit that's touching the gutta perca. So again, you don't need much. So we use the solvent with a file, and Hedstrom files are the best designed for this. You just look at the shape of the file, or the diagram here. It's designed to dig into something and pull it out. No other file is designed to do that. K-files, terrible instrument for retreatment. K-flex, the same. Reamers, all these things are not designed for what we want to do. So Hedstrom files are the most universal file for all the procedures we do. And again, start with a larger file, because you're not right down at the end of the canal. So if you've used your Gates Gliddens, you may be, say, half to 2/3 of the way down. And let's say it's a molar tooth, say a mesial root. Previous dentists might have gone up to, say, 25 or 30. If you come back a few millimetres, it's going to be the equivalent to maybe a 35 or a 40. So start with something like maybe a 30 or a 35. You go down maybe a millimetre or two with that file, then go down a size. So if you start with a 30, go down to your 25. Go to a bit further. You might even be able to get all the way down to the end of the canal. Maybe go to a 20 if you have to. But in these cases, I don't use things like 10s or 15s. They just bend. So start big and work your way down in size as you get down the canal. And the idea would be to insert your file until you feel the end of the root filling, then a slight rotation of the instrument, so you're engaging that softened gutta perca that's in the canal, softened because you've got the eucalyptus in there, and pull out, so bring the file out, and you'll have a bit of GP on it. Wipe it clean. I will have a piece of gauze in my hand, wipe it clean, do an anti-clockwise wipe on your gauze so you don't pull the gauze apart, and then go back in. Do the same again. Down till you feel the gutta perca, slight rotation so you can dig in, pull it out. As you come out, circumferentially around the canal, just like we do when the tooth's never been treated before, because you want to clean the walls of the cement. So in a case like that one, I said, we go down with our heated instruments first in the pulp chamber, then our Gates Glidden, in the distal we can probably get way down here with the Gates Glidden. We're going to get a little bit of GP with a file to remove. And the mesials we can probably get at least halfway, maybe a bit further with the gates, and then we use the solvents and files from there. This case that I showed you before is a little bit different because the root filling doesn't go all the way to the end. So we don't know whether the end of that canal has ever been instrumented before. So we basically follow this technique. I will go back to my small files to negotiate the canals here. If you remember I showed you that before, it had 2 canals. So, if you try to keep on going with big files, you're not going to get down there. So it just depends on whether the previous root filling went all the way or not as to what you would do once the GP is out. So what do you do then, once you've got all the GP out? Well, it's just root canal treatment as before. So you clean the canal, put your dressing in, and so on. Now, usually you're retreating because of an infected root canal system. The other time you might be retreating is, prior to doing a restoration, in which case you might have an infected root canal system, and I would assume that there's probably at least some bacteria in the tooth if you have to replace the restoration. So here we would not rely on Letimex paste by itself. We might use it as an initial dressing for a few weeks. They're the cases where we have an acute apical periodontitis where the patient's in a lot of pain. Most cases, though, we would start with a 50-50 mixture of Letimex with calcium hydroxide at the first appointment, so after we remove the root filling. And then the second appointment, which is usually when I complete the root canal preparation, I will then use calcium hydroxide by itself. And the reason for that is that calcium hydroxide has your best antibacterial action. And you can see here that typically I'm leaving dressings for at least a month, but there are many situations where we leave it for a lot longer and we may replace it with the mixture or calcium hydroxide by itself. We typically replace that every 3 months if we're doing a long-term treatment to get healing. But minimum 4 weeks, because that's how long it takes for pH changes out in the dentine. And you can see here, a few months of dressings, we see good signs of healing. Then we can be confident that that tooth can now go on and have a restoration done. So from the patient point of view, they know the treatment's working, and you know the treatment's working, so you can restore it. An example here of a case where a dentist did some root canal treatment, did a reasonable job there, but that radiolucency wasn't there when you did it. 6 months later it was. What was the problem here? Well, we retreated it, but as part of the retreatment, we removed the restoration and the caries. He didn't. And that's why this continued. So we did that, and retreated it. This is after a few months of dressings. It's getting better. There's our new root filling, interim restoration still there, and this is 6 months later. So it's really no different to how you were treated in the first place. How this guy should have. He should have got rid of the cause of the problem here before trying to do the root canal treatment. If you don't address the cause, the problem continues. The good news though, if you do have to do it again, start back at the basics and it generally will work. And if you follow that sort of process, good biological based principles to your treatment, you can get really good treatment outcomes. And here, this is part of a bigger study of 575 teeth, but there were 432 that had retreatment done. And these were all cases where we had followed them up until we knew the outcome. And you can see here that basically 98% of them healed, varying periods of time, up to about 4 or 5 years. There were a few cases where we weren't totally certain yet whether they were going to heal or not. And there were a few that didn't heal, which will happen. They're the ones where we'd go to surgery or maybe extraction. These ones we might continue to monitor depending on the time, and eventually we might have to get surgery or extraction, or some of them may heal. But you don't see too many studies that report that sort of outcome. Most of them are much lower. Interestingly, very few of them actually talk about uncertain cases. But I'm not showing this to say I'm better than anybody else. What I'm showing you this is because our approach to the treatment is very different. And none of these studies, and this is only a small number of studies in the literature, but none of them go through the process that we've been talking about for a long time now, and that's to remove all the causative factors. What could be causing the disease in this particular patient or in this particular tooth? So, and particularly also case selection. Only treat the teeth that are actually going to be okay to restore afterwards. Don't treat a tooth that's only going to last for a year or two. That's not fair on the patient. Might be okay for your pocket. It's not very good for the patient though when they come back, and it gives dentistry and endodontics a bad name. There might be other factors. We put a lot of effort into things like our interim restorations, and we have a slightly different irrigation regime to a lot of people and different medicament regime to a lot of people here. And we also use a lot of long-term dressings, which a lot of places, a lot of people don't do. But I think the most important thing is this here. Get everything out of the tooth, including the caries and the cracks, and don't think that the restoration is okay just because it looks okay. I can show you all sorts of other figures that show that that's not the case. So just to finish off with one final case, this one here, show, even things that look like they could be pretty much impossible to treat, such as here, post going all the way to the apex. You sort of wonder, why do you need a post that long? But somebody did it, but we were able to get that crown off and get the post out and retreat it, and we dressed it for a while. We were able to get some bone repair and a little bit of repair across that open apex, and we've got a good result. And a more conservative dentist has done a new post that's not so long. So it's possible to treat these cases as long as the tooth is okay to treat. And obviously in a case like this, you've got to get the crown off to be able to treat it. So that was partly how we sort of came to the conclusions that you really need to remove the restorations as part of your treatment, whether it's retreatment or the first time, and select your cases a lot better. So hopefully that's given you a few hints and tips and ways to do things, as well as a little bit of the theory behind it all. I'd just like to thank Alex for inviting me, and for all of you for coming along. It's been my pleasure to speak to the group again, and I'm happy to take questions if we have time.